sometimes being in an academic center, that would be my first choice. And actually, I have a good friend who unfortunately was gaslit for 2 years and got a delayed diagnosis, not breast cancer. She has a hematologic cancer, but hers is so significant now that it was grievous negligence what happened to her. Now she's at a very big academic medical center getting excellent care, but got mediocre care somewhere else. So I would say to your listener that has these concerns with this frequent screening, I would get a second opinion, which is completely reasonable. And then the other thing is if you know that you have to get an MRI every 6 months, or you're getting a mammogram alternating with an MRI, see about your flex spending or your HSA account so that you can set aside money that will help you pay for that. And here's the other thing. When you go for some of these tests, and if you don't have insurance coverage or you have limited insurance coverage, ask them for the cash price. Sometimes that is less than what they charge the insurance companies. And so I've had patients, this is sad, who needed MRIs and their insurance was like, okay, you're going to pay $3,000 out of pocket. But if they call and say, I want the cash price, maybe they pay $1,000.
All right. Well, it's a real pleasure to have Cynthia Thurlow on the show again. Welcome.
It's an easy yes to come back. It's always a pleasure.
I have so much fun speaking with you. I'm so glad you turned up to this because today we're going to cover mammograms and how to navigate this because we hear so much conflicting information. And I think we both grew up with that sort of get a mammogram to screen for breast health from the very beginning. And maybe you've been following the advice or not, I don't know. But my mother, she died of breast cancer when she was only 57 and she was getting regular mammograms every 6 months. So we were all so shocked when she was diagnosed at 55, which is actually the age I am today. So I'm really concerned, more than maybe someone else who hasn't had that history of breast cancer. And I've been getting regular mammograms for about once or a year, every couple of years, as advised by my doctor since I was probably in my 20s. Yeah. But now we're seeing on social media, the influencer doctors who are saying this is a big mistake. Mammograms can cause cancer. And then I'm like wondering, oh my God, what the hell am I doing? Should I be doing this or not? Why are my doctors telling me to get mammograms? And I know that I'm not the only one who is really questioning this and whether we should get them, if they're safe, are there alternatives? So today I want to really help that woman navigate through this information to help her find out what is really right for her. And that's why I've invited you, you're a nurse practitioner, to help us sort that out. And I really reached out to you because you actually interviewed Dr. Robin Roth. And that was when I reached out to you. I said, okay, like I've done an episode with her before too. There's been some controversy with that. And we both have interviewed people from both sides, like the pro mammograms, the anti mammograms. So you've actually even made a decision to remove some of your interviews. So can you walk us through what changed your mind and then why you felt it was important to remove some of those episodes?
Yeah. And I think that kind of my prevailing philosophy as a human being, but also as a clinician, and I take that very seriously. Like I have a responsibility to, and when I know better, I do better. And yes, I did have 2 episodes with this one physician. And it's funny, when the first episode aired, my cousin, who's a female physician, called me, and she never calls me about the podcast ever. And she said, I'm not saying that wasn't a good interview, but I'm a little concerned about what message that might send to people. And she said, by that, I mean, are people no longer going to get screenings because of what they heard on your podcast? And I took that really seriously. I was like, she's right. And I really need to be careful navigating going forward. And so I had that tucked in the back of my mind. I talked to my podcast team. I talked to my regular team. We decided to move forward. And then I stumbled upon Dr. Robin Roth's work. And it was almost like a bell went off in my brain. I was like, you know what? This is a breast radiologist. This is what she does day in and day out. And she's talking about the science behind screening our breasts. And this is someone who meets women every day that are being diagnosed with breast cancer. And so I reached out to her and I said, very transparently, I said, I have a podcast. I'm a nurse practitioner. There's something about your messaging that really resonated with me. Like, I think there's so much fear around certain types of screening, not just mammography, but other types of screening. Colonoscopy is another one. People, the stuff that came up last week, because I had a colonoscopy, was fascinating. I actually did a totally dedicated podcast to talking about screening for colonoscopies. And I'm not comparing either of them. But the point that I'm making is after I stumbled upon Dr. Roth's work and had a conversation with my team, I decided to take down these other two podcasts that I had done with this female physician. And I said, I want to bring Dr. Roth on and I want to do, again, with that prevailing philosophy of know better, do better. I was like, you know what? The things that she's saying are really compelling and they're very science and research oriented. And so she came on the podcast. We had an amazing time. I was very honest with her about my kind of evolution on this topic. And I said, listen, I'm not a breast health expert. I don't get mammograms every year. I kind of follow the European model, which generally is every 2 to 3 years because I'm at lower risk compared to other people in my demographic age range. With that being said, after speaking with her and interviewing her and sharing it with my community, the outpouring of positive comments and people saying, oh my God, I almost didn't get a mammogram. Oh my God, my sister almost didn't get a mammogram and then got diagnosed with DCIS, so this ductal carcinoma in situ. Oh my God, I almost skipped my yearly mammogram because of your original two podcasts. And now I'm so glad that I did it because I felt very conflicted because I trust your opinion. And yet now that you've talked very transparently about how you've come full circle. So the point of why I'm sharing that is I'm very open-minded, but there is no current screening modality that is better than a mammogram. And I think when people get concerned, and actually I went down a rabbit hole to prep for this podcast to be able to speak from a place of authenticity, the amount of radiation that we get from one mammogram is equivalent to flying across the country. And I was thinking about here in the United States, how often do I do that? I'm doing that sometimes every month. And that means it's not the mammogram that's giving me all the extra radiation. It is the actual flying. And looking at the FDA's information, it was talking about how much radiation you need to have in order to put yourself at a higher risk of developing any type of cancer. And so to give you an idea, they measure radiation from screenings like CAT scans, X-rays, mammography, and millisieverts. And so a mammogram is usually 0.4 millisieverts versus looking at CAT scans, which are much higher. And so it's interesting to me how we've kind of gotten off course. Does that mean that if you have 4 mammograms a year for 20 years, like over time, that is cumulative? But I think for the average person getting a screening mammogram every year or every other year, depending on what your comfort level is, the cost benefit is it's so much more in your favor to be able to pick something up earlier. There are other things like people will talk about thermography. People will talk about QT imaging. They're not equivalent. And so the gold standard right now, until something better is created, is a mammogram. And from my perspective, when I looked at the average person's risk versus people that have very dense breasts. And that's a whole separate conversation. People with very dense breasts have to start screening earlier. They have to start screening more frequently. But for the average person that's healthy weight, not diabetic, it's interesting. I was looking at the things that increase your likelihood of developing problems from getting serial mammograms. And it's dose dependent. It can be age dependent. If you have very large breasts, you're probably getting more than 4 views. You just start to think about the fact there's many things that impact screening and how successful it is. But I also think we have to reflect on looking at the science and is there something better? And right now, for breast health, there is not. Obviously, self-breast exams are important. I would be remiss if I didn't say that every woman should be examining their breasts every month to be able to discern for lumps or bumps or things that weren't there before. But in most instances, nothing has yet replaced a screening mammogram for evaluating breast tissue at this point in time.
Yeah, you've done some really good work, which is why I really wanted to have you on. And so some of the things that you've mentioned, the dense breasts, for example, 50% of the women have dense breasts. So it's not a small number.
Correct.
We need to remember that. And when I interviewed Dr. Robin Roth, it was because when I had this episode that was very anti-mammogram, I've had some of my listeners say, hey, hang on. Why don't you go look at Robin Roth's work and get her on? And so that's how I invited her. And I wasn't as kind to her as you were. Like I was really hard I threw out all the arguments of the anti-mammogrammers. Let's get an explanation about this. And she was amazing. She
Yeah.
handled it really well.
Yeah. No, she's incredible.
I really appreciate that because it wasn't, I'm sure it wasn't easy and it was a very long conversation, but she gave us some really good information and really good data. And here I go, confusing my audience even more. But I felt in my podcast, I always feel like I want to show both sides of the coin. It's like you can make the decision. You are a grown up girl, like you know what to do, but I just wanted to present the information. And I think she had some really important points. And I do remember that when I was researching her, well, actually, one of the questions I threw out her, and I'd like to know what you think, that you know, probably heard about, is that when we say, oh, it's equivalent to radiation is equivalent to flying overseas, the anti-mammogrammers would say, well, wait a second, this is localized. This is very
Correct. It's different. Right.
Do you
Yeah.
think it really is that different, or
Think about it like the radiation flying in an airplane is distributed, presumably. I don't know the physics of it. We say my husband's the physics guy, but it's not like it's localized to one body part. I'm assuming when we fly, it's systemic, it's not localized. And yes, we can make the argument that localized radiation is different. But if done appropriately and not overdoing it, like I think that the thing that I get concerned about, and I say this lovingly, I have many friends that have dense breasts, and every year they get very stressed thinking about, I'm either exposing myself to a mammogram every 6 months or a breast MRI. And that's kind of been, when I talk to the experts, that's kind of how they manage it. They do breast MRI, they do mammogram, and they're doing this every 6 months to evaluate because it's so much harder to look at their breast tissue than just fatty tissue when they're evaluating that. And when I spoke to Dr. Roth, I got the sense that despite the localization of the radiation, it is the only test right now, excluding an MRI, that's going to be able to give you that bit of information. Like, for an example, thermography just sees inflammation, and that is so nonspecific. QT imaging misses the clavicular area, it misses the axilla, where you can find lots of breast tumors. And if it's abnormal, you still have to have a mammogram. So I think that there's not technology yet that is able to adequately evaluate that tissue without some degree of radiation. And it's kind of being conscientious, looking at risk factors. Like, I had a good conversation with my GYN as an example. And I was saying to her, obviously, you're seeing thousands of women every month. And she's big on genetic screening, and I don't have any of the genetics for any of the breast or colorectal cancers. And every year it's like I get rescreened for the same thing. And I'm like, and she's like, that's right. Last year you didn't, you came up like you're not someone that we're particularly concerned about. And I said, given the fact that most cancers are not, it's like we know it's 1 in 8 women will develop breast cancer. And of those, very few are actually genetically mediated. It's like this aberrancy. Why are we seeing younger women with breast cancer? Why are we seeing so many younger women that are still at childbearing age and developing breast cancer? I think there's a lot of environmental factors. I think perchance there are factors we are not even yet aware of that are contributing. I certainly think poor metabolic health is not helping things. But I think that there's not yet another option that is efficacious. And that's what Robin kept saying was, listen, I'm a breast radiologist. I would love if there was technology that was available that reduced, like, it is still safe in the setting of 1 mammogram a year. It is still safe. But she said there's nothing that's as good or better right now. And if there was, the radiologist would be shouting it from the mountaintops. We would be totally behind it. We would be so excited about it. But that's just not the case. And so we have to go back to your point. Each one of us have to decide for ourselves what we are comfortable with. I am in a group where I was shocked, and I don't add a lot to this group, but I was in this group and people were just fearful of all screenings, pap smears, colonoscopies, mammography. I mean, you name it, they were fearful of it. And I just think that we have to look at screenings for what they are. It's designed to be able to see who's at greater risk and see who needs to be monitored more closely. But they're designed to screen. That is their purpose. They're just like, I just had a colonoscopy. I get them every 5 years because I have a bad family history. I've never had a polyp. Every time I go to get one, I just hold my breath. I'm like, okay, is this the year I'm going to get a precancerous polyp? Nope, great. So one less thing to worry about. But it doesn't mean we don't do it. So I think that each one of us has to decide based on our own genetics, risk factor, comfort level, whatever provides sanity for us. We have to decide for ourselves what makes sense. And I just shared with you, I am a board certified nurse practitioner and I do not get mammograms every year. I usually get them every 2 years. I do self breast exams every month. I'm very conscientious about that. I don't get them every year, but it doesn't mean I don't do them. Like, I want to be really clear. And just because I do it every other year doesn't mean it's the right decision for someone else. That's just what I have come to peace with. I talk to my physicians about it. They always say, well, we still recommend you have one every year. And I was like, I respect that, but I just do them every 2 years. And that's what I've done for the past 10 years. And that has been what works for me. I do not yet feel that any of these quote unquote alternatives would make me comfortable. Like, I did a thermography probably in my 30s just to kind of try it out. And I didn't walk away feeling like there was any valuable information from that for me personally. I've never done QT imaging. I don't even have a center close to where I live. But I wouldn't entertain doing that because it has limitations that would not make me comfortable, knowing that you can get tumors in the clavicular area in your axilla, which is your armpit, for those that aren't aware. Those are limitations I wouldn't feel comfortable with. Do I like getting mammograms? Absolutely not. They hurt. I'm just one of those people, like the last time I was like, that is the most painful mammogram I've ever had, but it's transient, it's temporary. Then it's done and it's over with. And thankfully, the center that's closest to my house, everyone there is very pleasant. So I'm like, okay, if I'm going to have my breast tissue squeezed between two plates and it's uncomfortable, it's all temporary and then it's done. And then I don't have to think about it again for a year or two. I'm curious for you, given your experiences interviewing different experts, what is kind of the prevailing philosophy on your part of, are you in Portugal or Spain right now? I know you go back and forth.
I know I go back and forth. So today I'm in Portugal. Day in Portugal. And so the way it works, I'm not so much sure in Portugal, but I've spent a lot of time in Spain. After the age of 50, the state sends you a message on your phone or they call you and they say every year you're entitled to a free screening, mammogram screening. So that's the way it is after the age of 50. Maybe that's changed. I don't know what it was before. But you go in and it's the same old routine, same thing, same machines. That's been the standard of care for a while now. Portugal, I imagine, is probably very similar. I'll find out very soon. But what I've concluded after talking to a lot of experts in this field and hearing both sides, I've come to conclusion that there's all these interesting screening tests. And by the way, with some of these anti-mammogrammers, I've had to literally stop them and say, she's not saying that she's anti-mammogram, period. If your audience is like, I'm not going to do this at all. Okay. There's maybe a time and place. Again, that's everyone's personal decision. But I think it's really interesting we have some other alternatives and they're not yet standardized. They haven't proven themselves yet, whether it's QT, thermography, the ARIA tier test. Like, I think these are all interesting. And the biohacker person in me goes, wow, another test. We like to test measure.
Yes, we do.
But I couldn't rely on that. And I always go back to Dr. Elizabeth Yurth, and you've interviewed her, right?
I have. She's lovely.
She's great. So when I was all confused, I said, let's get Dr. Yurth on. Let's see what she says. And she does have, and because she's not biased, she doesn't have, she's
not a radiologist. Yep. Nope.
No. And what we concluded with her was, yeah, these are interesting tools, add-ons to something that's really going to help you. And for some people, it will be the mammogram. It's easily accessible. For most people, we have access to this technology. So it's difficult to tell somebody, go do an MRI when they don't have the money to pay for this, or the insurance won't pay for it. So then that person doesn't screen at all. And that's no good. So we want to find something that really resonates with us and works with us. One of the problems I have is when a woman decides to go get the mammogram with so much fear in her body and her mind, like that can't be good either.
Well, that whole energy piece, and this sounds a little woo-woo, but I am a very spiritual person, and things that we internalize in terms of fear can manifest in ways that we don't want them to. And I'm not suggesting being fearful leads to any type of diagnosis. I'm just saying that it's not the right mentality to go into if you're going through these screening procedures. And I love Dr. Yurth's message, which is a very balanced, very bio-individual approach. And we can't forget the fact that a lot of people cannot afford, I mean, the healthcare industry in the United States is a shit show. And a lot of people have very basic care where the mammogram is covered, QT imaging is not covered, thermography is not covered, the ARIA test is not covered. MRIs may not be covered unless there's a clear-cut indication because they are not inexpensive tests. Trust me, because I've ordered plenty of MRIs over many years. But I think for a lot of individuals, it's like we forget that mammography is cost effective. Maybe people don't want to hear that, but I think my out of pocket for a mammogram is like $30. And people, we're still in a, whether it's the tariffs, whether it's whomever's in office, good or bad, I think a lot of people, it comes down to financial decisions. And so I always want to be sensitive to the fact that sometimes we have to make the most cost-effective choice, and that's okay. Like, I don't want anyone to feel shamed because they're like, well, listen, I don't want to spend $2,000 out of pocket to do an alternative when I can go to my neighborhood mammography center, get my mammogram done once a year, twice a year, whatever it is that needs to happen, and it's covered, and I don't have these huge out-of-pocket expenses. And so I think that's another piece of the conversation that sometimes I feel like we are so privileged that we exist in a space where maybe we can afford these gadgets or these fun things or these extras or these add-ons, but that might not be the case for everybody. And so I never want the message to be that cost should be the issue, but I also think, like, ultimately, what is the test that's going to yield the greatest benefit for the greatest amount of people over time? And until we have a better alternative, I just feel like mammography is a reasonable option, but something that for everyone who's listening, discuss with your provider, like whether it's a physician, a nurse practitioner, a PA, or whomever, discuss your fears, discuss your concerns, have a conversation. Hopefully you don't end up having to see a breast specialist. But if you do, you can go into it better informed. One of the things I found so interesting, and I don't know if you had this as a takeaway from Dr. Roth, but she had said, like, oh, I think eventually we're all going to develop breast. Like, that was just, she's like, I see so much that it's just not shocking to me anymore. Like she said, if I get to a point where I develop breast cancer, I know exactly what I'm going to do. So I was like, well, I guess if that's what you are inundated by breast health issues every single day, I'm sure you're very biased about, like, it's just normal to see that. But I think for the rest of us, we probably have some degree of discomfort with ever hearing that kind of diagnosis. Like, I had a callback once and my husband was traveling and I took one of my NP friends with me because I was so nervous about having to come back. And it was like, it turned out it was like a nipple shadow. And I was like, seriously, I had to come back because I have a nipple shadow on my mammogram. And the radiologist was like, oh, we should have just told you that. You would have had less anxiety. Yeah. And I was like, yeah, uh-huh. Yeah. I think Robin said it's like 9 out of 10 or 8 out of 10. It ends up being nothing. Like, they'd have callbacks. Mm-hmm. So it's definitely a small percentage. And she said, I generally know, like, the people when I'm looking through the callbacks, you know, that one or two people out of 100, she's like, I'm already certain I know what I'm seeing, but I have to bring them back just to get a closer look before we refer them on for biopsies and other diagnostic modalities.
One thing I think was really interesting that I think there's a point here when it comes to mammograms and these callbacks and what if, and we don't know. And it seems as though the technology is so good now. It gets everything. It's kind of like, if you search, you will find thing. Mm-hmm. And I think this is probably where I'm most concerned is, gosh, the stress, the unnecessary stress that happens. How often does that happen? It seems, I don't know the statistics, but everyone knows somebody, including me, who had that kind of a callback and a wait, and oh my God, I'm going to die. I'll never see.
Oh, it's on a Friday afternoon and there's like a holiday weekend and there's no one to talk to. Yeah, that's what happened to me.
Yeah, that stress can't be good. So I'm a little concerned about the technology. It's great. Maybe we're not there yet in terms of being able to analyze it and say what is really a concern that we do need to call this person back, because it seems as there's all these callbacks, all this stress, and that concerns me. And I don't like that. I want to get over that.
Well, I think there's a twofold issue. Number one, at least here in the United States, we have a very litigious environment. And I can tell you that most, if not all, providers are always in the back of their head thinking about I'd rather bring that person back than miss something. Just like I had patients in cardiology that I would say to students when I was working with them, you have to always in the back of your head be thinking about what's the thing that could knock this patient off the earth. And so I think that we are in a very litigious environment. That's both good and bad. But I do think that could potentially lead to overscreening, potentially. And don't ask me statistics. I'm talking about just at a population level, whether it's repeat labs, repeat diagnostics, repeat procedures. But I think people are so worried about being sued that may lead clinicians to have a really low threshold for repeating things. And I can't speak, I'm not a breast radiologist and I'm not a radiologist, but I would imagine that's no different in radiology, that the kind of the prevailing medical model we have right now, we practice very defensively. And again, good or bad, I think there's a degree of, we used to call it differential diagnoses. So in our mind, we see something that's pretty common. They used to tell us when you hear horse hooves, think about a horse and not a zebra, meaning more than likely what you're seeing is something common. It's not something rare, but you kind of tuck it behind in the back of your head, but like, oh, it could potentially be X, Y, or Z. But I think that degree of clinical aptitude plus or minus comfort level, like when I was first in healthcare, I worked in the ER. I'm going to give you a really relevant example. And there was a wonderful, very talented, smart physician who had been sued. And because he had been sued, he was so fearful of ever being sued again that he over-ordered stuff. And I'm not saying this is unique to this individual, but I think he was scared. It was a terrible experience to go through. He's a very good doctor, but he got sued. And we used to hate sometimes working with this individual because we would be doing extra tests in the ER. And it was because he was so fearful of ever being sued again. But there's definitely that kind of prevailing concern of, I don't want to miss anything, so I'm going to order a bunch of stuff. So just know as listeners that there is a bit of that in medicine right now, that people are fearful of being sued. Even though I have only a small group of patients I'm still working with, I still carry full malpractice insurance. I still carry the highest level of malpractice insurance because I want to protect myself and my family and my house and all the things. But I do think that is part of the conversation that maybe is not being, because it's kind of an ugly side, right? As I'm even saying this, I'm sure listeners are like, oh my God, that's horrible. But I do think it's a human side of this whole discussion that maybe we don't talk about enough as clinicians, like saying, yeah, I think about being sued. Thankfully, not all the time, but I do think for many people that are in the throes of practicing, you don't want to miss that kind of diagnosis. And so I think for a lot of people, they may overscreen, be overly cautious out of an abundance of concern to not end up getting sued.
And maybe overtreated. And that's also a concern. That scares me too, because it's not so much, I guess the breast cancer is fearful, but I think people are most afraid, not of dying, but of the horror stories that they've seen of people who get chemo and radiation and how it changes the quality of life. And so that's where we get that. Maybe perhaps one day in the future, we would be able to be given all the options and say, hey, we can do another test if you're concerned. And if you're not, fine, we can leave it. And yeah, unfortunately, we always leave all our power to the doctor. You decide for me, what would you do, kind of a thing. But I think we also need to empower ourselves and say, okay, we can make our own decisions and learn about these things. Yes, it's a pain in the butt to learn, get a PhD in breast cancer now because you have it. Like you know everything about it now.
You're like, it's a club I never wanted to be part of.
Exactly. So then the question would be if one day we can give that. And I think that's a smart choice. For example, I can give an example. My husband and me, we're very different mindsets. And so if somebody says you've got breast cancer or a lump or what, I'm like, just take it out, get it out as soon as possible. Like, I don't want it in there. Whereas my husband would be like, I don't know, let's see if it grows. Like he'd be totally chill. If the doctor says, well, we can do wait and see, he'd probably go, yeah, okay.
Yeah.
So I think when it comes to these kind of decisions, whether you're going to get a mammogram or whether you're going to go down the rabbit hole of different treatments, it has to be individualized because they have different mindsets and different approaches. So that's where it gets a little hard. And I think people just need to say it's not good or bad or this or that, black and white. It just depends on how you feel. And we have that. I just sent you a message of one woman in my community who shared her story of concern. Doctors found some kind of a lump and want her to come every 6 months. She's heard all my episodes and she's like, I don't know what to do. And the problem is also she has to pay a lot of money every time she has to go get a mammogram. It sounds quite a lot of money.
Yeah.
And I don't know where she's getting this, but she was stuck. What do I do? Because I don't want over radiation or over concern. She just kind of wants to forget about it.
Yeah.
And yet she has to pay all this money. So how would you approach that?
That's a great question. I would say number one, get a second opinion. Like I have a very good friend who has spoken publicly about her breast cancer diagnosis, and she was not satisfied with the first oncologist she met with at all. And she knows a lot and she's very smart and she's on top of the research. And so she had 2 or 3 consults. And I would say for anyone, there is no shame in getting a second opinion or even a third opinion. And it doesn't have to be that it's a breast health issue. It could be any type of pre-cancer, cancerous concern. Get another opinion. Go to a big academic center. You will probably get a differing opinion than from an oncologist or a radiologist team that's in a non-academic center. So whether people know this or not, the academic centers are generally doing a lot of research. They tend to be a little bit more up on current modalities. There may be more clinical trials that are involved in versus things kind of trickle down to the community, which can be fine to be screened there, but they may not be doing cutting edge, be on top of because we recognize in medicine, it takes 10 to 20 years for things to trickle down. So sometimes being in an academic center, that would be my first choice. And actually, I have a good friend who unfortunately was gaslit for 2 years and got a delayed diagnosis, not breast cancer. She has a hematologic cancer, but hers is so significant now that it was grievous negligence what happened to her. Now she's at a very big academic medical center getting excellent care, but got mediocre care somewhere else. So I would say to your listener that has these concerns with this frequent screening, I would get a second opinion, which is completely reasonable. And then the other thing is if you know that you have to get an MRI every 6 months or you're getting a mammogram alternating with an MRI, see about your flex spending or your HSA account so that you can set aside money that will help you pay for that. And here's the other thing. When you go for some of these tests, and if you don't have insurance coverage or you have limited insurance coverage, ask them for the cash price. Sometimes that is less than what they charge the insurance companies. And so I've had patients, this is sad, who needed MRIs and their insurance was like, okay, you're going to pay $3,000 out of pocket. But if they call and say, I want the cash price, maybe they pay $1,000. So it is a bit of a game and there is no shame. Like I've had some labs done where I'm like, I'll just do the cash price because I know my insurance company, it's the beginning of the year. I have to hit a certain deductible. I'm like, I have to pay out of pocket anyway. Just tell me what the cash price is. You would be amazed at how much money you potentially can save. But I think for someone like that who's getting screened so often, and if she has dense breasts or she's had a lesion that they're watching really closely, first thing is second opinion, preferably at an academic medical center. And you can Google. I mean, the really cool thing now is we have so much information available to us. You could put in whatever you have and then add academic like number 1 in the country. You want a top 5 oncology program. They will pull it up. There's probably someone doing research for exactly what you have. So that's the first thing I would do. And then secondary to that, if you're having frequent screenings, they're getting expensive, ask for the cash price. Like I think a lot of people don't realize that they have the ability to do that. And you're not sidestepping the system. You're just saying, I'm not going to use my insurance for this. What's the cash price? And more often than not, you're going to actually pay less because it's like the bargain basement price. It's what the radiology center wants to make back at a minimum. And they're like, okay, we'll make it less expensive because you're going to pay cash. There's no shame in that. I would definitely do that.
Just the whole insurance system in the US is
it's so crooked.
Like,
no, in fact, I've gotten to the point
have to
now
do this. It shouldn't have to do this.
There's nothing more frustrating than my insurance plan requires me to use a particular pharmacy that I hate. I'm on a first name basis with the pharmacist, the head pharmacist, like they know me by name. because I tell them all the time, I'm like, you guys suck. You never have what I need. Like, I have a particular brand of estrogen patch that I like, not the cheapy alternative. I want this brand. And for whatever reason, it's always out of stock. I'm like, but I can order it in another part of my state and get it at a different pharmacy, but you can't get it. And so there's a game. Like I tell them all the time, I was like, you guys are terrible. You're terrible as a prescriber and you're terrible as a patient. And so they always find that funny. They're like, we're sorry. I'm like, you guys suck. CVS. If you're in the United States, it's CVS. I'll just throw them under the bus.
Oh, the things we have to do to get what we need. And on top of it, you're paying top dollar. Most people are paying tons of money for insurance. I mean, I know in the US, a lot of people get it through their company, but someone's got to pay.
Do you know what's amazing? So my husband and I were talking the other day when we were first married, what we paid per month for the two of us. And when I say we don't use a lot of healthcare, like we're healthy people. Then we have two kids. Now I have two adult age sons, but they're still under our plan. And I said to my husband, I was like, the amount of money that we pay, and then we still have a deductible on top of that, it's almost criminal. Like you just think, if I was super unhealthy, I would hit the donut. We would hit it like in the first 2 months of the year, but it takes us all year
Yeah.
to hit the donut, to hit that threshold. And I'm like, oh my God, we've spent $10,000 on insurance. I'm grateful to have it. Let me be very clear. When my husband got sick last year, I was so appreciative. Everything was covered, but I just think about everyone's insurance coverage is getting more restrictive and in most instances more expensive because we are a less healthy population. And essentially, the healthy people are paying for everyone's care because we don't draw off of it. And the stuff that I use are like hormones. It's not like a lifestyle medication. So, sorry, I didn't mean to hijack the conversation, but it's one of these goofy things that's unique about the broken US healthcare system is that it's expensive. People pay a lot for insurance. I'm shocked at how many people tell me they're not insured and they're like, I just pray I don't have a catastrophic event. A lot of people go into bankruptcy because they have very expensive hospital bills. And that's an even bigger travesty, I think.
Yeah, this is it. This is like a whole podcast we could do
Yeah.
because it's a problem, and it would be interesting to share different healthcare systems around the world because they're not all that great either. Sometimes grass looks greener on the other side, but they have their other problems too. And there's pros and cons with each system. So let's wrap up about the. I want to talk about what concerns women so much. Why are we getting mammograms? Is they're worried for breast cancer, right? And we're worried about the radiation that we're getting. And we're worried that radiation may give you the breast cancer. But in fact, the real drivers of breast cancer are completely different. And we're not focusing on that, which I
Nope.
think we really need to do. And there's the alcohol and obesity, just to name a few.
Poor
So,
metabolic health is huge.
so yeah, I think we're kind of chasing down we're worried about the wrong things. I think our concern should be somewhere else. So how do you think that these drivers compare to any kind of risk that you get from radiation from a mammogram?
Yeah, I mean, I think it's easy to deflect attention on concerns over radiation exposure when the big elephant in the room is poor metabolic health and lifestyle issues. It's the not sleeping, it's not managing your stress, it's that you're physically sedentary. You eat a garbage standard American diet. You drink excessively. You smoke. You have toxic relationships. You're in a toxic environment. I think it's a cumulative net effect of our modern day lifestyles that is a larger issue, but it is so much easier to express fear over getting a screening than it is to address the lifestyle piece. And I'm the first person to say, lifestyle is everything. And if anyone thinks differently, trust me when I tell you, 25 years of being in clinical medicine, the patients that are generally doing the best overall are the patients that do all the things I just mentioned. They sleep, they manage their stress, they eat a nutrient dense whole food diet, they move their body, they have healthy, fulfilling relationships, they don't drink excessively. If they drink, they don't smoke. They try to limit their exposure to toxins. It's not possible unless you live in a bubble to have no toxin exposure. But, you know, you don't necessarily have to live pristinely. Like I love Dave Asprey, and Dave is hilarious. But sometimes they'll say things. I'm like, Dave, is that realistic for most people, though? Are most people going to be able to do those 10 things every day? I think if we focus on the lifestyle piece, and that's not trite, we are lessening our likelihood of ever going on to develop not just breast cancer, colorectal cancer, other types of cancers, poor metabolic health. So, diabetes, fatty liver disease, Alzheimer's, which we now acknowledge is this type 3 diabetes, dementia, poor bone issues, which when menopause, it's like all of a sudden women go from having some degree of metabolic health to going sideways and are suddenly dealing with insulin resistance and inflammation and obesity, being overweight. And so I think that I say this lovingly, I think it is convenient to deflect attention on concerns over screening modalities as opposed to dealing with the elephant in the room. And I say that with great love, but I feel like alcohol in particular is finally getting some attention about being a known carcinogen and how toxic it is. I think 10 years ago, people thought I was weird, but I'm glad that now we're starting to have these conversations because look at mommy drinking culture. I mean, here in the United States, it is huge. It's a huge problem. During the pandemic, post-pandemic, when patients say to me, I drink 2 to 3 glasses of wine a night, I double it. So whatever the patient tells me, in my head, I'm thinking, you don't really drink 2 to 3 glasses. You're probably drinking a bottle and a half. And so just understanding that lifestyle plays a huge role in overall health issues. Now, could you exist in a vacuum and do everything perfectly and still get cancer? Absolutely. I have plenty of friends that has happened to. It's been like shocking. But more often than not, it is this lifestyle piece that's not being addressed. It's much easier to say, just get that mammogram, but I'm not going to talk to my patient about losing weight, moving their body, strength training, managing their stress. Oh, they don't sleep more than 5 hours a night. Oh, let's not focus on that. Or they work night shift perpetually. We know that how hard that could be on our bodies and increase our risks of specific types of cancer like breast cancer. So I think that the bigger picture is lifestyle. If we want to be really myopic and be very fear-based and very, I don't know, I say this respectfully that I think sometimes people can't get out of their own way. It's almost like once they, that amygdala and overrides our prefrontal cortex and we get scared about something and then we lose executive function, we're just not thinking clearly. It's like, wait a minute, let's take 10 steps back and think about this differently. Let's objectively look at the research. We don't have to be perfect, but let's look at the research. Let's talk to the clinician. Let's talk with our significant other. Let's not make decisions based on fear. As uncomfortable as a mammogram is transiently, it's not an excuse not to get screened for 5 years. If you had a bad experience, then when you go in to have your next experience, tell them, I had a bad experience last time. You may need to go a little slower. You may need to explain more to me. You may need to take things a little more slowly, whatever it is. Just like women that fear getting pap smears or fear having colonoscopies or any other screening modality, talk about your concerns because if the clinician is a good one, they're going to take a couple extra minutes to reassure you, talk to you about your fears. They're not going to want you to be scared or frightened or uncomfortable. In the grand scheme of things, a lot of these are they're so temporary. It's like uncomfortable short term and then it's over with, like with the colonoscopy. Worst part's the prep, and then you take a nice nap, and then it's over with for another 5 or 10 years, depending on the individual. So you're fully adulting, and sometimes we just have to do things that's like not on my list of favorite things to do, but it's ultimately going to yield significant ultimate benefits.
I love how you said that. Thank you so much. I appreciate your time. I could talk to you forever, but I think we're going to have to end it here. But speaking of getting our health all sorted out, you have a book coming out really soon, The Menopause Gut. Can you tell us a little bit about what we can expect with that and when we can pre-order?
Yeah, thank you so much. The book is going to be published through Penguin Random House on April 28th, 2026, which is going to be here before we know it. But it's walking us through what's changing in the gut microbiome as we navigate perimenopause and menopause as a direct result of changes in our estrogen, our progesterone, our testosterone, and how that impacts our bone health, how it impacts how we age, how it impacts our immune system, how it impacts, when we go into menopause, which is fascinating, how the role of trauma impacts when we go into menopause. And so to me, it's a constellation of what I've learned on the podcast over the last, how many years have I been doing the podcast? 8 years. How many years I've been doing the podcast, all these experts that kind of distilled all of what I've learned into a really helpful book. I think it's a double entendre. So people are menopause gut and they're like, I don't like the menopause gut. I've got the menopause gut. And I'm like, it's really talking about the science behind what's going on in our microbiome and why it's so important. And certainly when I trained 20 plus years ago, we didn't know what the gut microbiome was. So it's really an explosion of science over the last 5 to 10 years, but myopically focused on women in perimenopause and menopause. So I think it's going to be a really impactful and exciting book for women.
Oof, I'm excited to read it and then talk about it with you in a future episode.
Absolutely.
Wonderful. Well, thank you so much to everyone who's made it to the end of the episode. I'm so grateful that you spent your time with us doing your due diligence and trying to learn more about mammograms and how to make that choice for you. So hopefully this was helpful for you to navigate through all the confusion. And thank you, Cynthia, for your time. And so appreciate you and all the work that you do. You're just such a shining light in this journey of menopause. So
Thank you, my friend.
have a wonderful day, and everyone else have a good night, good morning, good day, wherever you're at, and we'll see you next time.